Welcome to Easy Medicine. In these 3 high-yield clinical cases, focus on the clues that point directly to the diagnosis and train your Step 1 Case 1. A 28-year-old man is brought to the emergency department by his roommate because of a noticeable change in behavior over the last 2 weeks. He is normally responsible and organized, but recently quit his job as a computer programmer and started placing large bets online because he believed he was guaranteed to become a millionaire. He has also been staying awake most nights writing notes for his autobiography on tiny scraps of paper. The patient says, "My new mission is to spread understanding." Both the patient and his roommate deny alcohol or drug use. Question: what additional finding is most likely? The correct answer is pressured speech. This patient demonstrates a classic manic episode consistent with bipolar I disorder. The key findings are grandiosity, impulsive behavior, decreased need for sleep, and increased goal-directed activity. Patients with mania often have elevated or irritable mood, increased energy, racing thoughts, and speech that becomes rapid, excessive, and difficult to interrupt. Bipolar I disorder requires at least one manic episode, and episodes may occur with or without psychotic features. Acute treatment commonly includes mood stabilizers, such as lithium or valproate, and second-generation antipsychotics. Case 2. A 23-year-old woman presents because she cannot keep her legs still and feels unable to remain sitting or lying comfortably. 1 month earlier, she was diagnosed with schizophrenia and started treatment. After 2 weeks, the medication dose was increased. She says, "I stopped hearing voices shortly after the dose increased. On examination, she appears anxious, restless, and constantly moving." Question: what is the diagnosis? The correct answer is akathisia. This patient is experiencing akathisia, an extrapyramidal side effect associated with antipsychotic therapy. Patients commonly describe intense internal restlessness and an overwhelming need to move. Symptoms usually appear days to weeks after starting treatment or after increasing the dose. Patients may pace, shift position frequently, or feel unable to stay still. Management often includes reducing the antipsychotic dose or adding treatments such as beta blockers or benzodiazepines. Case 3. A 37-year-old man is admitted for right lower lobe pneumonia and initially improves after receiving antibiotics. However, during hospitalization, he develops new abdominal pain, diarrhea, and severe muscle aches. Examination reveals anxiety, dilated pupils, prominent lacrimation, and hyperactive bowel sounds. Question: what is the diagnosis? The correct answer is opioid withdrawal. This patient shows the classic presentation of opioid withdrawal. Symptoms commonly include nausea, vomiting, diarrhea, abdominal cramping, muscle pain, anxiety, lacrimation, dilated pupils, and increased bowel activity. Withdrawal may begin as early as 6 to 12 hours after stopping a short-acting opioid, and typically peaks within the first 24 to 48 hours. Case 4. A 54-year-old man comes to the office worried that he may have pancreatic cancer after a coworker died from the disease 6 months ago. He has no abdominal pain, jaundice, or weight loss. 2 months earlier, another physician performed a physical examination, laboratory testing, and an abdominal CT scan, all of which were normal. Despite reassurance, the patient remains concerned and now believes occasional stomach noises after eating could be a sign of cancer. He requests additional testing. Question: what is the diagnosis? The correct answer is illness anxiety disorder. This patient has excessive fear of having a serious illness despite normal medical evaluation. Patients with illness anxiety disorder often interpret normal body sensations as signs of disease and are rarely reassured by negative results. Unlike somatic symptom disorder, they have minimal or no physical symptoms. Pattern recognition is one of the fastest ways to improve for Step 1. Save this video and continue practicing with more high-yield clinical cases.
1. Patients who develop amenorrhea and galactorrhea during psychiatric treatment have disruption of the tuberoinfundibular pathway. 1.1. There are 4 major dopaminergic pathways in the brain. A. Mesolimbic pathway. B. Mesocortical pathway. C. Tuberoinfundibular pathway. D. Nigrostriatal pathway. Hyperactivity of the mesolimbic pathway causes positive psychotic symptoms such as hallucinations and delusions. 2. Acute stress disorder. 2.1. Clinical features include exposure to actual or threatened trauma. 2.2. Patients may experience intrusive memories, nightmares, and flashbacks. 2.2.3. They can also present with amnesia, detachment, and avoidance. 2.3. Negative mood and dissociative symptoms are common. 2.4. Sleep disturbance, irritability, and hypervigilance may be present. Symptoms last at least 3 days and up to 1 month. Acute stress disorder develops after trauma and may resolve within 1 month. If symptoms persist for more than 1 month, the diagnosis changes to post-traumatic stress disorder. 3. Manic episode. Clinical features include distractibility, impulsivity with risky behavior, grandiosity, flight of ideas, increased activity, decreased need for sleep, and talkativeness. A manic episode requires at least 1 week of elevated or irritable mood. At least 3 symptoms must be present, or 4 if the mood is only irritable. The condition causes impaired function. Psychosis may occur, and hospitalization may be required. 4. Antipsychotic side effect. Extrapyramidal symptoms include acute dystonia, which presents as sustained muscle contractions. Akathisia presents as inner restlessness. Parkinsonism includes tremor, rigidity, and bradykinesia. Tardive dyskinesia occurs with chronic use and causes involuntary movements such as lip smacking. Neuroleptic malignant syndrome presents with fever, muscle rigidity, changes in mental status, and autonomic instability. 5. Akathisia case. Medical case example. A 23-year-old woman presents with restlessness in her legs and inability to sit or lie still. She has schizophrenia and is taking antipsychotic medication. The diagnosis is akathisia. Akathisia is an extrapyramidal side effect characterized by inner restlessness and inability to remain still. Treatment includes reducing the antipsychotic dose if possible, or adding a beta blocker or benzodiazepine. 6. Withdrawal syndromes. Alcohol withdrawal presents with tremors, agitation, anxiety, delirium, and psychosis. Findings include seizures, tachycardia, and palpitations. Benzodiazepine withdrawal presents with tremors, anxiety, perceptual disturbances, and insomnia. Findings include seizures and tachycardia. Opioid withdrawal presents with nausea, vomiting, diarrhea, abdominal cramps, and muscle pain. Findings include dilated pupils, piloerection, lacrimation, yawning, and hyperactive bowel sounds. Opioid withdrawal can begin 6 to 12 hours after stopping a short-acting opioid such as heroin. Symptoms usually peak within 24 to 48 hours. It is generally not life-threatening, and vital signs are usually normal. Lacrimation and yawning are characteristic findings that help distinguish opioid withdrawal from other conditions.
Case 1. A patient with excessive worry about having pancreatic cancer despite a negative medical evaluation is consistent with illness-anxiety disorder, also known as hypochondriasis. Illness-anxiety disorder is characterized by excessive concern about having a serious undiagnosed disease despite few or no symptoms and a negative medical workup. Case 2. A patient with anxiety is diagnosed with panic disorder and receives a medication that has anxiolytic, muscle relaxant, and anticonvulsant properties. These medications are benzodiazepines, such as clonazepam or lorazepam. The mechanism of action is an increased frequency of chloride channel opening. Benzodiazepines act on gamma-aminobutyric acid receptors in the central nervous system, increasing the frequency of chloride channel opening in the presence of gamma-aminobutyric acid. Case 3. Oppositional defiant disorder. This disorder is characterized by a pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness lasting at least 6 months. Patients often argue with adults, defy authority figures, and refuse to follow rules. They may deliberately annoy others and blame others for their own mistakes or misbehavior. They are easily annoyed, angered, resentful, or vindictive. These symptoms are not explained by another mental disorder. Case 4. Conduct disorder. This disorder involves a pattern of violating major societal norms or the rights of others over the past 12 months. Patients may show aggression and cruelty toward people or animals. They may destroy property or set fires. They may seriously violate rules such as truancy or running away. They may also engage in deceitfulness or theft, including lying or stealing. The difference between oppositional defiant disorder and conduct disorder is that oppositional defiant disorder involves angry and defiant behavior toward authority figures without severe violations. Conduct disorder includes more serious behaviors such as physical aggression, stealing, and destruction of property. For example, setting fire to a locker room is consistent with conduct disorder.
Case 1. A patient has unresolved issues with his father and becomes upset when his psychiatrist cancels an appointment, believing the psychiatrist is not interested in him. This is an example of transference. Transference is the unconscious shifting of emotions or expectations from past relationships onto a person in the present, often originating from early relationships with parents. Case 2. Frontotemporal dementia is characterized by aggregation of tau protein and other protein inclusions, along with early neuronal loss in the frontal and temporal lobes. In contrast, Alzheimer's disease involves early neuronal loss in the parietal and temporal lobes, with neurofibrillary tangles and amyloid plaques. Patients with frontotemporal dementia have impaired executive function and poor work performance. It is an early-onset dementia characterized by prominent behavioral changes. These include disinhibition, apathy, loss of empathy, and impaired social relationships. Patients may develop hyperorality and changes in diet, often with a preference for sweets. Severe cases may include binge eating and compulsive behaviors such as repetitive speech, hoarding, or adopting new rigid behaviors. Case 3. Certain medications increase the effect of methadone, including fluconazole, voriconazole, ketoconazole, ciprofloxacin, clarithromycin, cimetidine, and fluvoxamine. Methadone can cause overdose characterized by somnolence, pinpoint pupils, and respiratory depression. It can also prolong the quart interval and increase the risk of dangerous arrhythmias. For example, fluconazole can increase methadone levels and lead to overdose. Case 4. A patient with alcohol withdrawal presents with agitation, disorientation, tremors, hypertension, and tachycardia after a period of abstinence. Alcohol withdrawal occurs due to decreased inhibitory activity and increased excitatory activity in the brain. Chronic alcohol use reduces gamma-aminobutyric acid receptor activity and increases glutamate receptor activity. When alcohol is stopped suddenly, this leads to central nervous system overexcitation. The key mechanism is increased activity of glutamate receptors. Chronic alcohol use decreases inhibitory receptor activity and increases excitatory receptor activity. Sudden cessation leads to decreased inhibition and increased excitation, resulting in symptoms such as agitation, disorientation, tremors, and autonomic instability. Psychotic disorders. Case 5. Brief psychotic disorder lasts at least 1 day but less than 1 month, with sudden onset and full recovery. Schizophreniform disorder lasts at least 1 month but less than 6 months, with symptoms similar to schizophrenia but without requiring functional decline. Schizophrenia lasts at least 6 months and includes at least 1 month of active symptoms, with functional decline. Schizoaffective disorder includes both mood symptoms and psychotic symptoms, with at least 2 weeks of psychosis without mood symptoms. Delusional disorder involves at least one delusion for 1 month or more, without other psychotic symptoms and with relatively preserved functioning. Case 6. A patient presents with lethargy, poor coordination, slurred speech, and rapid improvement, along with a rash around the mouth and nose. This presentation suggests inhalant use. Inhalants include substances such as glue, toluene, nitrous oxide, amyl nitrite, and spray paints. They are commonly used by adolescents because they are inexpensive and easily available. They are inhaled through cloths, bags, or direct sniffing. They act rapidly on the central nervous system and cause short episodes of euphoria, lethargy, disorientation, and impaired coordination. Effects usually last between 15 and 45 minutes. Case 7. A patient has difficulty with writing but not with reading or mathematics, and this causes anxiety. This is consistent with a specific learning disorder affecting writing. Learning disorders involve difficulties in key academic skills such as reading, writing, or mathematics, resulting in performance below expectations for age. Case 8. A patient treated with monoamine oxidase inhibitors for depression needs to switch to a selective serotonin reuptake inhibitor. A 2-week washout period is required after stopping the first medication before starting the new one. This prevents serotonin syndrome and allows enzyme activity to recover. Case 9. A patient receives haloperidol and develops abnormal facial movements and tongue protrusion shortly after. This is an acute dystonic reaction. It is caused by dopamine receptor blockade in the brain and presents with sudden involuntary muscle contractions. Examples include facial grimacing, neck spasms, upward eye deviation, and severe muscle rigidity. Treatment includes anticholinergic medications such as diphenhydramine or benztropine. Second-generation antipsychotics are commonly used as first-line treatment for schizophrenia because they have a lower risk of movement disorders. However, they are associated with weight gain and metabolic complications, including diabetes. Olanzapine and clozapine have the highest risk of these side effects.
This video discusses sensitive topics related to mental health. If you or someone you know is struggling, please consider reaching out to a qualified healthcare professional. Support is available, and seeking help is an important step toward recovery. You are not alone. So, in this second part, we continue with high-yield psychiatry cases focusing on trauma-related conditions and eating disorders. We will analyze a classic presentation of dissociative amnesia and review how to differentiate it from other stress-related disorders. Then, we will cover anorexia nervosa and its key clinical features, including how to distinguish it from bulimia. These are essential topics for exam success and real-life clinical practice. Case 4. A 17-year-old girl is evaluated after the accidental drowning of her younger sister 1 week ago. The patient attempted to rescue her but was unable to do so. She cannot recall any details of the event. She is alert and oriented but becomes distressed when the incident is discussed. The most likely diagnosis is dissociative amnesia. Dissociative amnesia involves an inability to recall important personal information related to a traumatic event. It is usually localized or selective and occurs suddenly after severe stress. The diagnosis requires ruling out substance use and neurologic causes. Adjustment disorder does not cause severe amnesia. Complicated grief requires longer duration. Conversion disorder presents with neurologic symptoms, which are absent. Post-traumatic stress disorder includes additional symptoms such as hyperarousal, nightmares, and avoidance, and must persist for more than 4 weeks. Case 5. A 20-year-old college student presents with fatigue and decreased exercise tolerance. She reports fear of gaining weight and states she must keep running to avoid becoming fat. She has difficulty concentrating, depressed mood, constipation, and abdominal bloating. Her appetite is normal, but she admits to self-induced vomiting. Physical examination shows dry skin, bilateral parotid swelling, pharyngeal erythema, and hypoactive bowel sounds. Her BMI is 17.5. The most likely diagnosis is anorexia nervosa. This patient has significantly low body weight, distorted body image, and purging behaviors. A BMI less than 18.5 is a key feature. There are two subtypes. The restricting subtype involves fasting and excessive exercise. The binge-purge subtype includes vomiting or use of laxatives and diuretics. Physical findings include bradycardia, hypotension, hypothermia, dry skin, and lanugo. Electrolyte abnormalities such as hypokalemia and metabolic alkalosis are common in the purging subtype. In contrast, bulimia nervosa presents with normal or increased body weight, recurrent binge eating, and compensatory behaviors, along with a strong preoccupation with body image.
This video presents high-yield psychiatry cases for medical students preparing for exams such as the USMLE. Each case focuses on key clinical concepts, diagnosis, and important distinctions that are commonly tested. Case 1. A 30-year-old woman with a history of major depressive disorder presents with concern that her depression is returning. She reports decreased appetite, poor sleep, difficulty concentrating at her job as a teacher, and social isolation. She has access to both new and old medications at home. She has no personal history of suicide attempts, but her mother died by suicide at age 40. The question is, what is the most important factor in assessing this patient's suicide risk? The correct answer is access to medication. Suicide risk assessment is based on evaluating ideation, method, and intent. Suicidal ideation can be passive, such as wishing to die or not wake up, or active, such as thoughts of killing oneself. The method includes thoughts of a specific plan, access to means such as medications or firearms, and the lethality of the method. Preparation includes actions such as collecting pills, obtaining a weapon, giving away valuables, or writing a suicide note. Planning involves specific details such as time, place, and method. Intent refers to the strength of the patient's desire to act on these thoughts and the time frame. In this patient, although there are multiple risk factors, the most concerning feature is preparation, specifically collecting medications with a potential plan for overdose. Hospitalization may be necessary to ensure safety. Case 2. A 21-year-old woman presents with constipation and abdominal pain. Review of systems reveals irregular menses and occasional fatigue. She smokes 1 pack of cigarettes daily and drinks alcohol socially. Vital signs show hypotension and tachycardia. Physical examination reveals dental enamel erosion. The most likely diagnosis is bulimia nervosa. This patient's findings are consistent with self-induced vomiting, including electrolyte abnormalities such as hypokalemia and metabolic alkalosis. Additional findings may include calluses on the dorsum of the hand, known as Russell sign, and parotid gland enlargement. Bulimia nervosa is characterized by recurrent binge eating followed by compensatory behaviors such as vomiting, laxatives, fasting, or excessive exercise. Patients are excessively preoccupied with body weight and typically have a normal or increased body weight. Symptoms include abdominal pain, bloating, constipation, lethargy, and menstrual irregularities. Case 3. A 40-year-old man is diagnosed with major depressive disorder and started on antidepressant therapy. After several weeks, his symptoms improve slightly, but he develops decreased libido and impaired sexual performance. He is considering stopping the medication and requests an alternative. The most appropriate medication is bupropion. Selective serotonin reuptake inhibitors are commonly used as first-line treatment for depression, but can cause sexual dysfunction in up to 50% of patients. These effects include decreased libido, anorgasmia, and delayed ejaculation. Bupropion is a norepinephrine dopamine reuptake inhibitor that does not typically cause sexual dysfunction. It is useful in patients with low energy and hypersomnia and causes less weight gain. However, it is contraindicated in patients with eating disorders and seizure disorders due to decreased seizure threshold. Stay tuned for Part 2, where we cover trauma-related disorders and key eating disorder distinctions with high-yield clinical insights. We will review how to manage antidepressant-induced sexual dysfunction and how to differentiate dissociative amnesia from other stress-related conditions. These are key concepts frequently tested on exams and highly relevant in clinical practice.
A patient with euphoric mood, decreased need for sleep, hyperactivity, grandiosity, and pressured speech lasting more than 1 week is experiencing an acute manic episode. Bipolar disorder is a recurrent condition that requires maintenance therapy to prevent relapse. Maintenance treatment options include lithium, valproate, lamotrigine, and quetiapine. Valproate is an anticonvulsant with mood-stabilizing properties and is effective for maintenance therapy. Passive-aggressive behavior. A patient agrees to complete medical forms but submits only a signature and says, "I am sure a doctor with your education can take a good history." This is an example of passive-aggressive behavior. It represents indirect expression of anger. Instead of openly expressing frustration, the patient complies superficially but resists completing the task. Other examples include procrastination, forgetfulness, intentional inefficiency, sarcasm, and denial of anger. Defense mechanisms. Immature defense mechanisms include acting out, expressing unacceptable feelings through actions. Denial, refusing to accept reality displacement, transferring emotions to a safer target. Intellectualization, focusing on facts to avoid emotions. Passive aggression, expressing hostility. Indirectly projection, attributing one's own feelings to others. Rationalization, justifying behavior to avoid discomfort. Reaction formation, converting feelings into their opposite. Regression, returning to earlier developmental behavior. Splitting, viewing others as all good or all bad. Mature defense mechanisms include sublimation, channeling impulses into acceptable activities. Suppression, consciously setting aside emotions. Schizophrenia and dopamine. Positive symptoms of schizophrenia, such as hallucinations and delusions, are caused by increased dopamine activity in the mesolimbic pathway. This pathway projects from the ventral tegmental area to the limbic system. Antipsychotic medications act as dopamine antagonists and reduce these symptoms. Dopamine blockade in other pathways explains many side effects. Opioid use disorder treatment. Methadone is used for opioid withdrawal and maintenance therapy. It is a full mu opioid receptor agonist with a long half-life. Its long half-life allows suppression of cravings and withdrawal symptoms and reduces the euphoric effects of other opioids. Adverse effects include QT interval prolongation and respiratory depression. High-functioning autism. A 13-year-old boy with social deficits, lack of friends, restricted interests, and difficulty with reciprocal interaction is consistent with high-functioning autism spectrum disorder. Patients diagnosed later often have normal or near-normal language and intellectual ability. Post-traumatic stress disorder, PTSD, post-traumatic stress disorder. PTSD occurs after exposure to a life-threatening traumatic event. Symptoms include intrusive memories, flashbacks, nightmares, avoidance, emotional detachment, negative mood, sleep disturbance, hypervigilance, and irritability. Duration must be at least 1 month. Acute stress disorder, ASD, acute stress disorder. Symptoms are similar to PTSD but last from 3 days to 1 month after trauma. If symptoms persist beyond 1 month, the diagnosis becomes PTSD. Brief psychotic disorder. This disorder presents with sudden onset of psychotic symptoms such as delusions or hallucinations lasting more than 1 day but less than 1 month. Adjustment disorder. A 61-year-old woman with insomnia, anxiety, and stress after divorce and relocation is most consistent with adjustment disorder. Symptoms occur within 3 months of a stressor and resolve within 6 months after the stressor ends. Symptoms cause distress and impairment but do not meet criteria for another psychiatric disorder. Acute stress disorder requires trauma and lasts up to 1 month. Generalized anxiety disorder requires symptoms lasting more than 6 months. A normal stress response is milder and does not cause significant impairment. D.D.
Case 1. A patient with severe hypertension presents after eating aged meats and cheeses. She has a history of treatment-resistant depression. The most likely cause is a hypertensive crisis due to a monoamine oxidase inhibitor interacting with tyramine-rich foods. Monoamine oxidase is an enzyme that breaks down neurotransmitters such as dopamine, norepinephrine, and serotonin. Inhibition of this enzyme leads to excess monoamines. Tyramine ingestion further increases catecholamines, causing severe hypertension, headache, and autonomic symptoms. Case 2. A patient develops tremulousness, agitation, and elevated heart rate and blood pressure within 48 hours of hospital admission. This presentation is consistent with alcohol withdrawal. Alcohol enhances GABA activity, which is the main inhibitory neurotransmitter in the brain. Abrupt cessation decreases inhibitory tone, leading to central nervous system hyperactivity. Symptoms begin within 8 to 12 hours and include insomnia, anxiety, tremors, and autonomic instability. Seizures may occur within 12 to 48 hours. Special topic: delirium tremens, characterized by confusion, agitation, and fever, typically occurs within 48 to 96 hours. Benzodiazepines such as lorazepam, diazepam, and chlordiazepoxide are the first-line treatment. They enhance GABA activity and help prevent seizures and progression to severe withdrawal. Long-acting benzodiazepines are preferred because they provide a smoother and self-tapering effect. Autism spectrum disorder, ASD, autism spectrum disorder. Autism spectrum disorder is characterized by deficits in social communication and interaction, with onset in early childhood. Patients have impaired social engagement, impaired nonverbal communication, such as poor eye contact and limited gesturing, and difficulty developing or understanding relationships, including reduced interest in peers. They also present restricted and repetitive patterns of behavior, such as repetitive movements or speech, insistence on sameness or routines, intense fixated interests, and adverse responses to sensory input. Autism spectrum disorder may occur with or without language impairment and intellectual disability. Diagnosis and management focus on early identification and early intervention. Treatment is comprehensive and multimodal, including speech therapy, behavioral therapy, educational support, and pharmacologic treatment for psychiatric comorbidities. Case 3. A 2-year-old boy with lack of social engagement, speech delay, and repetitive play is consistent with autism spectrum disorder. Autism is more common in boys. Symptoms are often apparent by the 2nd year of life, and diagnosis is typically made before age 5. Case 4. A patient with schizophrenia is started on clozapine. The most important parameter to monitor regularly is the absolute neutrophil count. Clozapine is indicated for treatment-resistant schizophrenia and schizophrenia associated with suicidality. Adverse effects include agranulocytosis, seizures, myocarditis, and metabolic syndrome. Clozapine has superior efficacy in treatment-resistant schizophrenia. It binds loosely to dopamine D2 receptors, which results in fewer extrapyramidal symptoms compared to first-generation antipsychotics. Due to the risk of life-threatening agranulocytosis, regular monitoring of ANC is mandatory. Case 5. In a patient with chronic alcohol use, the earliest symptom of withdrawal is tremulousness. Withdrawal symptoms can begin as early as 6 hours after the last drink, peak within 2 to 3 days, and resolve within 4 to 5 days if not severe. Early symptoms include tremor, anxiety, insomnia, nausea, vomiting, and mild autonomic hyperactivity such as tachycardia and increased respiratory rate. Tremor, also called the shakes, is typically the earliest and most common symptom. This is the most severe form of alcohol withdrawal. It typically occurs 48 to 96 hours after the last drink.
A father of a 5-year-old boy asks the physician if it is normal that his son prefers to play with dolls instead of trucks or cars like other boys. The most appropriate response is, "I understand your concern. Let me reassure you that many boys play with dolls as a normal part of exploring the world. Gender refers to the internal sense of being male, female, or a combination of both. Children begin to understand gender between ages 3 and 4, and develop a sense of gender permanence around ages 5 to 6. When a child has a persistent and intense feeling that their gender does not match their assigned sex at birth, this may continue into puberty. If this causes significant distress, it is diagnosed as gender dysphoria. These patients have higher rates of depression and anxiety and require monitoring and support. A 29-year-old woman presents with symptoms of depression. She reports similar episodes at ages 23 and 27. She also describes brief periods lasting several days when she felt unusually confident, energetic, and productive, functioning on only 3 to 4 hours of sleep. The most likely diagnosis is bipolar II disorder. This patient has a current major depressive episode lasting more than 2 weeks, with depressed mood, low energy, hypersomnia, increased appetite, decreased concentration, and loss of interest. She also has a history of hypomanic episodes, characterized by increased activity, energy, confidence, and decreased need for sleep. Bipolar II disorder is defined by at least one major depressive episode and at least one hypomanic episode. Hypomanic episodes are less severe than manic episodes, do not involve psychosis, and cause less functional impairment. An adult patient presents with symptoms of an acute manic episode, including increased activity, decreased need for sleep, racing thoughts, pressured speech, and grandiose and paranoid delusions. He is hospitalized and treated with antipsychotic medication. 5 days later, he develops fever, confusion, abnormal vital signs, and muscle rigidity. The diagnosis is neuroleptic malignant syndrome. This is a life-threatening complication caused by dopamine blockade. It can be triggered by antipsychotics, such as haloperidol, antiemetics, such as promethazine, or withdrawal of Parkinson medications. The pathophysiology involves central dopamine receptor blockade, leading to hyperthermia, autonomic instability, and muscle rigidity. Key features include fever, altered mental status, generalized rigidity, diaphoresis, and unstable vital signs. A 19-year-old man develops behavioral changes after the death of his father. He becomes socially withdrawn, stops progressing academically, and spends most of his time alone drawing repetitive number patterns related to his father's death. He denies hallucinations and suicidal ideation. The most likely diagnosis is schizophrenia. Schizophrenia typically presents in early adulthood, earlier in men than in women. It often has a gradual onset, but can be triggered by a stressor. Diagnosis requires at least 6 months of symptoms, including at least 1 month of active phase symptoms. These include delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms. Negative symptoms include apathy, social withdrawal, flat affect, reduced speech, and anhedonia. Although positive symptoms are more characteristic, some patients predominantly present with negative symptoms, which are more difficult to treat. Treatment includes antipsychotics such as risperidone and olanzapine, which are more effective for positive symptoms. Diagnosing major depressive disorder in patients with cancer can be challenging because somatic symptoms overlap with cancer-related symptoms and treatment side effects. Weight loss, fatigue, and sleep disturbances may be caused by the illness itself rather than depression. Therefore, non-somatic symptoms are more reliable. These include feelings of worthlessness, excessive guilt, loss of interest, social withdrawal, and suicidal ideation. A patient with severe hypertension presents after eating aged meats and cheeses.
This video discusses topics related to mental health and psychiatric conditions for educational purposes only. The content is intended as a learning tool for medical students preparing for licensing exams and is based on high-yield academic material. This is not medical advice and should not be used to diagnose or treat any condition. If you or someone you know is experiencing mental health concerns, it is important to seek help from a qualified healthcare professional. Support is available, and you are not alone. In this video, we will review high-yield psychiatry cases focused on anxiety disorders, learning mechanisms, personality disorders, and neurocognitive conditions. Case 1: we have a 30-year-old woman with overwhelming anxiety and stress. She has had increasing job-related pressure over the past 6 weeks. She reports sudden episodes where she becomes very nervous and then feels shaky, dizzy, and nauseated, followed by sweating. One episode occurred while speaking with her boss. She is especially worried about having an episode during work meetings, but these episodes have also occurred while she was relaxing at home. Because of this, she has stopped seeing her friends, as she never knows when the symptoms will appear. She has no significant medical history and does not use alcohol or drugs. Her vital signs are normal, and both physical examination and laboratory evaluation show no abnormalities. The question is, what is the most likely diagnosis? The correct answer is panic disorder. This patient has recurrent episodes of acute anxiety accompanied by physical symptoms such as shaking, dizziness, nausea, and sweating. These are characteristic features of panic disorder. The diagnosis requires recurrent, unexpected panic attacks that reach a peak within minutes, followed by persistent concern about future attacks or changes in behavior to avoid them. Patients often restrict their activities due to fear of having another episode. Physical symptoms may include chest pain, shortness of breath, tachycardia, as well as gastrointestinal and neurological symptoms. A key feature is that some attacks occur spontaneously without a clear trigger, such as when the patient is relaxing at home. For diagnosis, it is important to rule out medical and substance-related causes, such as hyperthyroidism and alcohol withdrawal. Panic disorder should also be differentiated from other psychiatric conditions where panic attacks are triggered by specific situations. Acute stress disorder involves exposure to a traumatic event, followed by symptoms such as re-experiencing, avoidance, and hyperarousal, lasting from 3 days to 1 month. Adjustment disorder with anxious mood is associated with an identifiable stressor, but symptoms do not meet criteria for another mental disorder. In this case, the presence of unexpected panic attacks makes panic disorder more likely. Generalized anxiety disorder involves excessive worry for at least 6 months about multiple areas such as work, health, or finances. In contrast, panic disorder is centered on recurrent unexpected panic attacks and fear of future episodes. Social anxiety disorder involves panic symptoms triggered by social situations, with a strong fear of negative evaluation by others. Case 2. A 30-year-old graduate student with a history of recurrent ear infections during childhood feels anxious and begins to sweat when she is in the examination room with her physician. She recently got a roommate who is a nursing student and leaves her stethoscope on the coffee table. After returning home from class, the patient notices that whenever she sees the stethoscope, she begins to sweat and feels her heart racing. The question is, what is the most likely explanation for this response? The correct answer is classical conditioning. This patient's reaction to the stethoscope is an example of classical conditioning. During childhood, visits to the physician for ear infections acted as an unconditioned stimulus, producing anxiety. These medical encounters were repeatedly associated with the presence of a stethoscope. Over time, the stethoscope became a conditioned stimulus. Classical conditioning also explains white coat hypertension, wear a physician's white coat. Case 3. A 40-year-old man who works as a software engineer prefers to work remotely from home to avoid interacting. He rarely leaves his apartment and spends most of his free time on his computer, reading online forums about space exploration and alien life. He states that he has always preferred being alone. During childhood, he spent a significant amount of time disassembling and rebuilding electronic devices and had very few friends. The question is, what is the most likely personality disorder? The correct answer is schizoid personality disorder. This patient shows a pattern of social detachment, preference for solitary activities, and limited emotional expression. Individuals with schizoid personality disorder typically have little interest in relationships, including intimate or sexual relationships, and often have few close connections outside of family. They may appear indifferent to feedback and prefer independent work environments, which can affect occupational functioning. Antisocial personality disorder involves violating the rights of others and engaging in unlawful or aggressive behavior without remorse. Avoidant personality disorder involves social isolation due to fear of rejection, despite a strong desire for relationships. Obsessive-compulsive personality disorder is characterized by excessive concern with order, control, and perfectionism. Paranoid personality disorder involves distrust and suspicion of others as the main reason for avoiding relationships. Schizotypal personality disorder includes eccentric behavior, perceptual disturbances, and magical thinking, such as beliefs in telepathy or clairvoyance. Case 4. A 70-year-old woman presents with memory concerns that began 1 year ago and have gradually worsened. She forgets conversations with her son and often walks into a room only to forget what she intended to do. She lives independently and has no difficulty cooking, cleaning, or managing her finances. On examination, she is alert and oriented, with no focal neurological deficits. She scores 22 out of 30 on the Montreal Cognitive Assessment. The question is, what is the most likely diagnosis? The correct answer is mild cognitive impairment. This patient has objective evidence of memory impairment, as indicated by her cognitive assessment score, but she remains independent in her daily activities. This is consistent with mild cognitive impairment, also known as mild neurocognitive disorder. In contrast, dementia, or major neurocognitive disorder, involves cognitive decline that interferes with daily functioning. Case 5. A 27-year-old woman is brought to the emergency department due to increasingly paranoid and disorganized behavior over the past year. She has had progressive difficulty performing her work responsibilities. Over the past 6 months, she has become more secretive and recently began speaking in a whisper because she believes that listening devices are hidden in the walls. She has also started hiding food and personal belongings. She does not use alcohol or illicit drugs. During the interview, she frequently changes topics and reports hearing voices that harass her. The question is, what is the most likely diagnosis, and which additional mental status finding is most likely present? This patient has paranoid delusions, disorganized speech and behavior, auditory hallucinations, and a 1-year history of functional decline, all of which are consistent with schizophrenia. Schizophrenia includes positive symptoms such as delusions, hallucinations, and disorganized thinking, as well as negative symptoms such as flat affect, apathy, reduced speech, and social withdrawal. Flat affect is characterized by decreased facial expression, monotone speech, and poor eye contact. Negative symptoms tend to persist over time and are less responsive to treatment. Although cognitive impairment can occur, patients are typically oriented and do not have fluctuating levels of consciousness, which helps distinguish schizophrenia from delirium. Auditory hallucinations are the most common type in schizophrenia. Other types, such as olfactory or tactile hallucinations, are less common and are more often associated with substance use or neurological conditions.
In this video, we review high-yield psychiatry cases focused on key clinical presentations frequently tested on exams. We will break down each scenario step by step to help you identify diagnoses and understand management clearly and efficiently. Case 1: we have a 62-year-old woman who comes to the office for worsening hypertension. The patient admits that she is not taking her antihypertensive medication. She feels fine and says that she always listens to her body rhythms when deciding whether to take medication on a particular day. She also mentions that she has crystal jewelry with healing powers, and she participates in an online forum about the health benefits of crystals. The patient does not trust most people and believes that she can predict the weather based on the number of birds in her yard. She lives alone, has a few friends, and is unemployed. On examination, the patient makes limited eye contact and appears mildly anxious. She has no auditory hallucinations, and no specific delusions are elicited. The question is, what is the most likely explanation for this clinical presentation? In this case, the patient has schizotypal personality disorder. This patient's eccentric behavior, odd thoughts, perceptual distortions such as belief in bodily rhythms, and social anxiety are consistent with schizotypal personality disorder. Patients with this disorder typically exhibit magical thinking, such as superstitiousness and clairvoyance, along with perceptual disturbances that are subthreshold for a psychotic disorder. These patients do not experience the persistent fixed delusions or frank hallucinations seen in schizophrenia. Schizotypal personality disorder is characterized by a long-standing pattern of eccentric behavior, odd beliefs, perceptual distortions, and social anxiety despite familiarity. Case 2. A 25-year-old man is brought to the emergency department by ambulance after being found sitting in the street drinking his own urine. He says that he is being watched by an unidentified government agency. He subsequently broke up with his girlfriend, quit his job, and disconnected his phone. He no longer seems to care about activities that used to interest him, and last month he moved into the family garden shed with his dog. The patient is malodorous, disheveled, and appears drowsy for no apparent reason. During the interview, he becomes angry and refuses to sit in a chair. Vital signs are normal. Physical examination and laboratory evaluation are normal. What is the most likely diagnosis in this patient? This patient has schizophrenia. His symptoms include delusions, disorganized speech such as loosening of associations and nonsensical words, and grossly disorganized behavior including unpredictable agitation, bizarre actions, and inappropriate affect. He also has functional decline lasting greater than 6 months. Other symptoms may include hallucinations and negative symptoms such as affective flattening, apathy, alogia, anhedonia, and asociality. Schizophrenia has an overall prevalence of approximately 1% worldwide and is slightly more common in men. It typically presents in the early 20s in men and in the late 20s in women. Most patients follow a fluctuating course in which symptoms peak and then diminish, leaving residual symptoms such as mild disorganization, mild negative symptoms, or mild hallucinations at baseline. The treatment of choice for schizophrenia is antipsychotic medication. Diagnosis requires at least 2 of the following symptoms: delusions, hallucinations, disorganized speech, grossly disorganized behavior, and negative symptoms, with a total duration of impairment of at least 6 months. In this second part, we continue with high-yield psychiatry cases, focusing on developmental behavior and mood-related conditions. These cases will help you differentiate normal findings from pathology and recognize key clinical patterns for exams. Please note that this video includes sensitive mental health topics. This content is intended strictly for educational purposes to support medical learning. It is not meant for diagnosis or treatment. If you or someone you know is going through a difficult time, seeking help from a qualified healthcare professional is strongly recommended. You are not alone. Case 3: we have an 11-month-old boy who is brought to the office by his mother for a well child visit. The mother reports that the baby has been crying and screaming when other people approach him. She is concerned because this has been occurring for the past few months and seems to be worsening. She says that he used to enjoy being held by everyone, but now wants to be only with her and does not even allow his grandmother to hold him. The patient is crawling and can stand only with assistance. He babbles but does not say clear words and uses hand gestures to communicate. Growth curves are appropriate. On physical examination, the patient clings to his mother and begins crying, turning his head away when the physician attempts to interact with him. The question is, what is the most likely explanation for this behavior? Possible options include adjustment disorder with anxiety, autism spectrum disorder, normal development, reactive attachment disorder, and separation anxiety disorder. Although autism spectrum disorder may be considered, the correct answer is normal development. This patient's distress when interacting with unfamiliar people is typical of stranger anxiety, a normal developmental stage that begins around 6 months of age. It is characterized by crying, screaming, and clinging when unfamiliar individuals approach, even in the presence of the caregiver. The development of stranger anxiety indicates that the infant has formed a specific attachment to the primary caregiver and can distinguish that person from strangers. Stranger anxiety typically peaks around 9 months of age and resolves by approximately 2 years of age. Adjustment disorder would involve a response to a stressor that is disproportionate and associated with impairment, which is not the case here. Autism spectrum disorder should be considered if there is persistent poor eye contact, lack of joint attention, and no response to name between 12 and 15 months. However, in this patient, the behavior is consistent with normal development. Case 4: a 53-year-old woman comes to the office due to chronic anxiety and tension. She worries constantly about multiple aspects of her life, including work, finances, and family. She has difficulty concentrating and frequently calls to check on the safety of her husband and children. She also reports tension headaches, back pain, and fatigue. She denies feeling depressed and states that her sleep and appetite are normal. Laboratory results are normal. In addition to psychotherapy, pharmacologic treatment with buspirone is initiated. The question is, what is the diagnosis? This patient has generalized anxiety disorder. Her chronic excessive worry about multiple domains, along with symptoms such as muscle tension, impaired concentration, and fatigue, are characteristic of this condition. Another question is, what property is associated with this medication? Buspirone has no risk of dependence. It is a non-benzodiazepine anxiolytic used for generalized anxiety disorder and does not carry the risk of dependence seen with benzodiazepines.
Welcome to Easy Medicine, your go-to resource for high-yield medical concepts made simple. This channel is designed as a supportive learning tool to help you review key topics anytime, anywhere, whether you're studying for Step 1, on the go, or reinforcing difficult concepts. Before we begin, a brief and important note. The following content discusses psychiatric conditions. This material is intended strictly for educational purposes. It is not a substitute for professional medical advice, diagnosis, or treatment. If you or someone you know is struggling with mental health, seeking help from a qualified professional is essential. Case 1. A 38-year-old woman comes to the office to address breast tenderness and absent menstrual periods over the last 3 months. She has a history of schizophrenia and familial hypercholesterolemia. Her medications include risperidone, which has improved her psychotic symptoms, and atorvastatin. Her BMI is 26 kilograms per meter squared, down from 36 months ago after following a strict diet. Laboratory studies, including a basic metabolic panel and thyroid function tests, are normal. A urine pregnancy test is negative. What is the most likely explanation for this patient's amenorrhea? The correct answer is drug-induced amenorrhea. This patient likely has hyperprolactinemia caused by risperidone. Risperidone blocks dopamine D2 receptors. Normally, dopamine inhibits prolactin release from the anterior pituitary. When this inhibition is removed, prolactin levels rise. Elevated prolactin can cause galactorrhea, breast tenderness, and suppression of gonadotropin-releasing hormone. This leads to central hypogonadism and amenorrhea. Case 2. A 27-year-old man with schizophrenia presents to the emergency department with an acute muscle spasm in his neck that began a few days after starting haloperidol. He is unable to turn his head and appears distressed. He is treated with intravenous diphenhydramine, which rapidly resolves his symptoms. Psychiatry recommends discontinuing haloperidol and starting quetiapine. In addition to dopamine D2 receptor antagonism, what is another pharmacologic property of this new medication? The correct answer is serotonin 2A receptor antagonism. This patient developed an acute dystonic reaction, a type of extrapyramidal symptom caused by a first-generation antipsychotic. These drugs strongly block dopamine D2 receptors, leading to motor side effects. Second-generation antipsychotics like quetiapine block both D2 and 5-HT2A receptors. They have lower affinity for dopamine receptors and a higher relative effect on serotonin receptors. This reduces the risk of extrapyramidal symptoms. However, these medications are associated with an increased risk of metabolic side effects. Before we continue, it is important to clarify a key concept. Gender dysphoria does not classify a person's identity as a disease. Being transgender or identifying with a gender different from the assigned sex at birth is not a mental disorder. The diagnosis is only made when there is significant emotional distress or impairment caused by this incongruence. In clinical practice, the goal is not to change identity, but to support the patient and reduce psychological distress. It is also important to mention that all the content in this video is based on high-yield information derived from official question banks and standardized exam material. These are the exact concepts commonly tested and expected to be understood in medical board exams. Case 3. A 15-year-old boy is brought by his parents due to concerns about his behavior. He has a long-standing interest in fashion and prefers female friendships. Recently, he bought women's clothing and began wearing makeup. His parents are concerned about bullying after a recent school change. When interviewed privately, he states, "I have always wanted to be a girl." He feels distressed about deepening voice and development of facial and pubic hair. What is the most likely explanation? The correct answer is gender dysphoria. This patient demonstrates a persistent desire to be female and significant distress about male secondary sexual characteristics. This reflects incongruence between gender identity and assigned sex at birth. Patients often express this from early life and may desire to change their physical characteristics. They may also adopt behaviors, clothing, and social roles aligned with their identified gender. Early recognition and support are key for improving long-term outcomes. Case 4. A 5-year-old girl is brought by her mother due to concerning behavior. The child has been speaking to an empty chair and says she sees her grandmother at night. Her grandmother passed away 2 months ago and previously lived with the family. Since then, the child has been tearful and frequently asks when her grandmother will return. What is the most likely diagnosis? The correct answer is normal behavior. Children often experience transient hallucinations after the loss of a loved one. These experiences can be comforting and are part of the grieving process. In the absence of other psychiatric symptoms, this does not indicate mental illness. Young children do not fully understand death. They may believe it is temporary or reversible. Management involves reassurance, emotional support, maintaining routines, and providing honest, age-appropriate explanations. Case 5. A 22-year-old college student presents with chronic tension headaches and neck pain. These symptoms have worsened over the past 7 months. He feels overwhelmed with school, has difficulty concentrating, and experiences frequent worry about academics, health, and social life. He also reports poor sleep and fatigue. What is the most likely diagnosis? The correct answer is generalized anxiety disorder. This patient has excessive, persistent, and uncontrollable worry, lasting more than 6 months. Symptoms include muscle tension, headaches, sleep disturbance, fatigue, and impaired concentration. Patients often worry about multiple aspects of life and may experience somatic symptoms. First-line treatment includes cognitive behavioral therapy and medications such as SSRIs or SNRIs. Case 6. A 16-year-old boy presents for a routine visit. He reports decreased appetite, weight loss, loss of interest in activities, fatigue, and difficulty concentrating. He sleeps excessively, but still feels tired. He is also irritable and struggles with school performance. What is the most appropriate next step? The correct answer is to assess for suicidal ideation. This patient shows signs of major depressive disorder. In adolescence, depression often presents with irritability rather than sadness. Key symptoms include anhedonia, weight changes, fatigue, poor concentration, and academic decline. Suicide is a leading cause of death in this age group. Any adolescent with these symptoms must be directly assessed for suicidal thoughts, as this determines urgency and management. If you found this helpful, you're already building a strong, high-yield foundation. This is Easy Medicine, where complex topics are simplified for real understanding. If you want to keep mastering psychiatry and other Step 1 essentials, make sure to subscribe and continue with the next video. Your consistency today is what builds your clinical intuition tomorrow. Welcome to Easy Medicine. If you're preparing for Step 1 or strengthening your clinical knowledge, this channel is designed to make high-yield medical concepts simple, clear, and easy to remember. In today's video, we'll go through key psychiatry cases, breaking them down step by step so you can understand not just the correct answer, but the reasoning behind it. All cases are based on high-yield Q-bank-style concepts commonly tested in exams. Let's get started. Case 1. A 67-year-old man presents to the hospital with an acute worsening of chronic back pain, now associated with new-onset bilateral leg weakness and numbness. His medical history is significant for colorectal cancer, with vertebral metastases, for which he has undergone colectomy, chemotherapy, and radiation therapy. He currently takes oral morphine sulfate for pain control. On physical examination, there is focal vertebral tenderness, decreased muscle strength, reduced sensation to light touch, and spasticity in both lower extremities. Imaging studies reveal a vertebral compression fracture with spinal cord compression. Surgical decompression is planned. The question is, which drug may precipitate opioid withdrawal symptoms in this patient? The correct answer is buprenorphine. Opioids act by binding to G-protein-coupled opioid receptors, mimicking endogenous opioid peptides. However, long-term activation of mu-opioid receptors can lead to tolerance and opioid-induced hyperalgesia, meaning increased sensitivity to pain. Withdrawal symptoms can occur within 24 to 48 hours after abrupt cessation and include nausea, vomiting, myoclonus, dilated pupils, diaphoresis, and tachycardia. Buprenorphine is a partial opioid agonist with high receptor affinity. It can displace full opioid agonists from the receptor, acting functionally as an antagonist and precipitating withdrawal in opioid-dependent patients. Case 2. An 18-year-old woman presents with low energy, decreased appetite, insomnia, poor concentration, and reduced interest in daily activities. She has lost 3.6 kilograms over the past month. She has no prior psychiatric history. She is started on medication. 3 weeks later, she is brought to the emergency department because she has not slept for 3 consecutive nights. She reports that she does not feel tired despite the lack of sleep. She has spent a large amount of money on plane tickets and plans to travel the world to promote peace. Her mother reports a history of severe mood swings. Which medication was most likely started 3 weeks ago? The correct answer is sertraline. Initially, the patient presented with symptoms consistent with major depressive disorder, including low energy, anhedonia, weight loss, insomnia, and impaired concentration. She was appropriately started on a selective serotonin reuptake inhibitor. However, she now presents with symptoms of mania, including decreased need for sleep, increased energy, impulsive spending, and grandiosity. Antidepressants can induce mania, especially in patients with an underlying predisposition to bipolar disorder. This risk is higher in patients with a family history, as seen in this case. If a patient develops manic or hypomanic symptoms while on antidepressants, the medication should be discontinued. Case 3. A 32-year-old man is diagnosed with major depressive disorder and started on a selective serotonin reuptake inhibitor. At his 2-week follow-up visit, he reports that his mood has not significantly improved. He continues to feel sad, unmotivated, irritable, and has difficulty sleeping and concentrating. He initially experienced nausea and worsening insomnia after starting the medication, but these symptoms have since resolved. He is discouraged by the lack of improvement and worries that he may never get better. What is the most likely explanation for his lack of response? The correct answer is duration of treatment. This patient has classic symptoms of major depressive disorder and is being treated appropriately with an SSRI. However, antidepressants typically require time before clinical effects are seen. Although some patients may experience early improvement within 2 weeks, an adequate trial is generally considered to be at least 4 to 6 weeks. At this stage, the most likely explanation for the lack of improvement is insufficient duration of therapy. The patient should be encouraged to continue the medication for at least a few more weeks before making changes. Case 4. A 40-year-old man is brought in by his wife due to behavioral changes over the past year. He was previously outgoing and energetic, but has become withdrawn, depressed, and emotionally distant. He has lost interest in his work and has difficulty making decisions. Over the past month, he has developed increasing paranoia, believing that his business partner and even the government are trying to harm him. He has no prior psychiatric history. His father and grandfather both died in their 50s after being admitted to long-term care facilities. On examination, he demonstrates random, abrupt, uncoordinated movements of his limbs. He appears restless and irritable, with clear delusional thinking. What is the most likely diagnosis? The correct answer is Huntington disease. This patient presents with psychiatric symptoms, choreiform movements, and a strong family history, all of which are characteristic of Huntington disease. Huntington disease is an autosomal dominant neurodegenerative disorder caused by CAG trinucleotide repeat expansion in the HTT gene. It typically presents in midlife and is characterized by chorea, psychiatric symptoms such as depression, irritability, and psychosis, and later progression to dementia with prominent executive dysfunction. Case 5. A 24-year-old man is hospitalized after a violent episode in which he destroyed his television. Over the past year, he has believed that people on television are monitoring his thoughts and that newscasters are mocking him. He also reports hearing voices of demons threatening him. He is diagnosed with schizophrenia and initially treated with chlorpromazine. However, he dislikes the side effects and has switched to flufenazine. Compared to chlorpromazine, what side effect is more likely with flufenazine? The correct answer is muscular rigidity. First-generation antipsychotics are divided into low and high-potency agents. Low-potency agents, such as chlorpromazine, are associated with sedation, anticholinergic effects, and orthostatic hypotension. High-potency agents, such as flufenazine, are more strongly associated with extrapyramidal symptoms due to dopamine D2 receptor blockade in the nigrostriatal pathway. These include dystonia, akathisia, Parkinsonism, and muscular rigidity. Case 6. An 8-year-old boy is brought for evaluation due to behavioral concerns. His parents report that he does not listen, is constantly moving, interrupts others, and frequently forgets tasks or loses items. They initially believed he would outgrow these behaviors, but they have progressively worsened. What is the most helpful step in establishing the diagnosis? The correct answer is teacher evaluations. This patient's symptoms are consistent with attention deficit/hyperactivity disorder, which includes inattention, hyperactivity, and impulsivity. The diagnosis of ADHD requires that symptoms be present in more than one setting, such as home and school, and that they cause functional impairment. Teacher evaluations are essential because they provide objective observations of behavior in the classroom over time and help confirm whether symptoms are consistent and excessive compared to peers. They may also include standardized rating scales to assess severity and monitor response to treatment. If this video helped you understand these concepts more clearly, make sure to like and subscribe to Easy Medicine for more high-yield case-based reviews. The goal of this channel is to help you learn efficiently and reinforce the most important concepts for your exams. If you want to continue learning, check out the next video in this series and keep building your medical knowledge step by step. See you in the next one.
Welcome back to Easy Medicine. In today's psychiatry review, we'll work through two very different but high-yield clinical cases. First, we'll learn how to recognize the behavioral clues that point toward frontotemporal dementia. Then, we'll switch to developmental milestones and identify what findings should raise concern during a routine pediatric visit. Let's get started. Case 9. A 50-year-old previously healthy man is brought by his wife after being forced into early retirement due to poor work performance. He previously worked as a financial planner but began missing deadlines and mismanaging accounts 6 months ago. He became increasingly irritable and started insulting coworkers when they expressed concern. At home, he has become verbally abusive toward his wife but appears indifferent to the impact of his behavior. His wife has assumed responsibility for finances and shopping. She also reports, "My husband has developed quite the sweet tooth. He eats almost 2 boxes of cookies every day." Physical examination is unremarkable. This patient most likely has which neuropathologic finding? The correct answer is aggregation of phosphorylated tau protein. This patient most likely has frontotemporal dementia, an early-onset dementia characterized by prominent behavioral and personality changes. Clinical features include disinhibition, socially inappropriate behavior, apathy, loss of empathy, impaired relationships, hyperorality, and dietary changes, especially increased preference for sweets. More advanced cases may present with binge eating or even ingestion of non-food items. Compulsive behaviors may range from repetitive speech or movements to complex rituals, hoarding, or abrupt adoption of intense new interests. Frontotemporal dementia involves degeneration of the prefrontal cortex with progression into the anterior temporal lobes. Neuropathologic findings often overlap with other neurodegenerative disorders and include aggregation of phosphorylated tau protein and abnormal TDP-43 inclusions. Case 10. A 3-year-old boy is brought to the office for a well-child visit. His mother reports that aside from an ear infection last year, he has been healthy. The child recently started preschool. He plays with other children and often imitates their actions but does not engage in make-believe play like his older sister. He knows his age and sex and can speak in 3-word sentences. He rides a tricycle but cannot hop on one foot. He also cannot use a spoon or fork and prefers eating with his hands. He scribbles spontaneously but cannot copy a circle. Which developmental milestone is most likely delayed? The correct answer is fine motor development. Developmental milestones are skills achieved by most children at predictable ages and are categorized into gross motor, fine motor, language, cognitive, and social domains. Routine evaluation of these milestones is essential to monitor healthy development. Failure to achieve multiple milestones or significant delay in one area warrants further assessment. Typical gross motor milestones at age 3 include riding a tricycle and climbing stairs with alternating feet. Hopping on one foot is not expected until approximately age 5. A 3-year-old should also speak in simple 3-word sentences and know their age and sex, which this patient does. Socially, children at this age interact with peers and frequently learn through imitation. Imaginative or make-believe play generally develops closer to age 4. The concerning finding in this patient is delayed fine motor development. At age 3, children should be able to copy a circle, use utensils, and manage simple clothing tasks such as buttoning loose garments. Because this patient cannot use utensils or copy a circle, additional evaluation is indicated. Today we reviewed how behavioral changes can reveal neurodegenerative disease and how developmental milestones help identify delays early in childhood. These are classic concepts that reward pattern recognition and clinical reasoning. Continue with the next cases and keep strengthening your high-yield foundation one case at a time. Welcome back to Easy Medicine. In today's high-yield psychiatry review, we'll work through 2 classic Step 1 style cases. First, we'll explore conduct disorder and learn how to distinguish normal adolescent behavior from serious violations of social rules. Then, we'll move into one of the most important psychotherapy concepts for exams and clinical practice, transference. Let's begin. Case 7. A 12-year-old boy is referred for evaluation of behavioral problems. His parents are concerned about poor grades and a recent school suspension after he set fires in the locker room and stole another student's cell phone. They report that he has always been impulsive, energetic, and easily angered, but over the last year his aggressive behavior has become significantly worse. The patient claims the fires were accidental but admits feeling angry at the coach for removing him from the basketball team. Regarding the theft, he jokes, people deserve to have their phones stolen if they are stupid enough to leave them in plain sight. He has a history of talking back to teachers, skipping classes, and getting into fights since 4th grade. He has no medical history. Family history is notable for bipolar disorder and alcohol dependence. The patient occasionally smokes cigarettes but denies alcohol or illicit drug use. Which of the following is the most likely diagnosis? The correct answer is conduct disorder. This patient's history of fire setting, stealing, aggression, and violation of rules is most consistent with conduct disorder. Conduct disorder is a psychiatric disorder of childhood and adolescence characterized by persistent behaviors that violate major societal norms or the rights of others. Other manifestations include bullying, recurrent physical fights, using weapons such as bats, guns, or knives, cruelty to animals, breaking into houses, and sexual coercion. Conduct disorder typically develops in middle childhood through adolescence and is more common in boys. Children with conduct disorder are at increased risk of developing antisocial personality disorder later in life. Case 8. A 48-year-old man begins psychotherapy due to depression and escalating conflicts with his boss. During therapy, he reports improvement in mood and develops insight into how emotionally unavailable his father was during childhood. He recently told his father, "I am angry that you were never there for me." The following week, the psychiatrist unexpectedly cancels a session due to an emergency. At the next appointment, the patient says, "I feel like you are not interested in listening to me, like I am not your priority." Which is the most likely explanation for this patient's attitude toward the psychiatrist? The correct answer is transference. Transference refers to the unconscious redirection of emotions and expectations originally associated with important figures from the past onto someone in the present. These emotions commonly originate from early relationships, especially with parents. When the psychiatrist canceled the appointment, the patient's unresolved feelings toward his emotionally unavailable father were unconsciously transferred to the therapeutic relationship. Transference may be positive or negative and plays an important role in both psychiatric and non-psychiatric doctor-patient relationships. Positive transference may strengthen trust in healthcare providers. In contrast, patients with histories of abuse may struggle to seek care or follow treatment due to expectations of rejection or harm. Today we reviewed two key psychiatry topics: conduct disorder and transference. These concepts appear frequently because they test both clinical reasoning and understanding of human behavior. If this helped simplify psychiatry for you, continue with the next cases and keep building your high-yield foundation one case at a time. Welcome back to Easy Medicine. Today we'll review two high-yield psychiatry cases for Step 1, panic disorder treatment and oppositional defiant disorder. Let's make these concepts simple. Case 5. A 20-year-old graduate student comes to the office for evaluation of anxiety. She describes episodes of sudden onset palpitations, shortness of breath, and diaphoresis during which she feels an intense urge to leave before anyone notices. Because of these episodes, she arrives early to class to sit close to the door and has even left lectures due to feeling out of control. There are no specific triggers, but she is increasingly worried about having another episode during her final examination next week. She does not drink alcohol or use illicit drugs. Physical examination, electrocardiogram, and laboratory evaluation are normal. The patient is diagnosed with panic disorder. After discussing treatment options, she decides to pursue cognitive behavioral therapy and start a short-term anxiolytic medication that also has muscle relaxant and anticonvulsant properties. Which of the following best describes the mechanism of action of this medication? The correct answer is increased frequency of chloride channel opening. Benzodiazepines such as clonazepam and lorazepam bind to and modulate GABA-A receptors on neurons in the central nervous system, increasing the frequency of chloride channel opening in the presence of GABA. This increased chloride permeability hyperpolarizes and stabilizes the neuronal membrane, making it less excitable and producing the anxiolytic, muscle relaxant, and anticonvulsant effects of benzodiazepines. Due to the risk of dependence, benzodiazepines are generally prescribed for short-term use in anxiety disorders and alcohol withdrawal syndrome. Case 6. A 12-year-old girl is brought to the office for an annual checkup. Her mother expresses concern about her daughter's behavior and poor grades. She describes her as stubborn, irritable, overreactive, emotional, and says she does not listen. The patient also appears resentful toward her twin brother and deliberately annoys or upsets him. Her mother says, "I cannot get her to do chores, finish homework, or go to bed on time." Over the past year, the school guidance counselor has contacted the mother several times due to the patient talking back to teachers and skipping classes. The patient states that school is boring and blames her behavior on pointless rules and unreasonable demands, adding that her teachers are stupid. Which of the following is the diagnosis in this patient? The correct answer is oppositional defiant disorder. This patient demonstrates a persistent pattern of deliberately annoying behavior and defiance toward rules and authority figures that is causing impairment both at home and at school, which is consistent with oppositional defiant disorder. Additional features include blaming others for failures and displaying anger, argumentativeness, and resentment. Although symptoms often appear first with family members, they must also occur during interactions with others. For diagnosis, the behavior must be excessive in frequency and duration compared with age-appropriate expectations. Adolescents commonly test limits and seek independence. However, this patient's one-year history of persistent defiance, skipping classes, repeated refusal to follow rules, and irritable mood exceeds normal developmental behavior. This disorder should be distinguished from antisocial personality disorder, which involves disregard for and violation of the rights of others and is not diagnosed before age 18. It should also be differentiated from conduct disorder, which involves more severe and aggressive behaviors. This patient does not exhibit destruction of property, physical aggression, cruelty to people or animals, theft, or deceit. If this helped you review faster, save this video and continue with the next cases. High-yield medicine made simple. Today we are going to review 5 high-yield psychiatry clinical cases focused on postpartum mood disorders, pediatric parasomnias, cognitive assessment, and substance intoxication. These are classic Step 1 style scenarios designed to improve pattern recognition, clinical reasoning, and understanding of important neuropsychiatric mechanisms. Case 1. A 24-year-old woman calls the office after giving birth to a healthy baby boy 5 days earlier. She reports experiencing emotional ups and downs and says, "I thought I would be thrilled to have a baby, but I feel really disappointed it was not a girl and cannot help but cry." The patient receives help from her sister during the day and is able to take naps, but she still feels exhausted because she wakes up during the night to feed the baby. She also says, "I get so worried that I am not doing things right. I am breastfeeding, but it's been harder than I thought it would be." The patient has no medical or psychiatric history, and the pregnancy and delivery were uncomplicated. She denies suicidal ideation and has no thoughts of harming the baby. The question asks which of the following is the most appropriate statement. The correct answer is, postpartum hormonal shifts can cause mood changes, but I would like to talk more about how you are doing. Would you be able to come in for an appraisal evaluation? This patient most likely has postpartum blues, a very common and usually self-limited condition that occurs shortly after delivery. Patients commonly develop mild depressive symptoms, emotional lability, intermittent sadness, tearfulness, irritability, exhaustion, and self-doubt. Symptoms typically begin 2 to 3 days after delivery and generally resolve within 2 weeks. Management usually includes reassurance, psychosocial support, and observation. However, it is important to distinguish postpartum blues from postpartum depression, which is major depressive disorder with peripartum onset. Both conditions may share symptoms such as tearfulness and sleep disturbance. In addition, many patients underreport depressive symptoms because they feel ashamed, inadequate, or fearful that they are not fulfilling expected maternal roles. Statements such as, "I am not doing things right," may indicate deeper emotional distress and should always be evaluated carefully. For this reason, patients who report mood symptoms shortly after delivery should undergo prompt evaluation for postpartum depression rather than waiting until the routine 6-week postpartum visit. An in-person assessment is preferred over a telephone evaluation because face-to-face interaction encourages discussion of sensitive topics such as guilt, hopelessness, suicidal ideation, or thoughts of harming the baby. The most appropriate response is therefore to validate the patient's experience, assess immediate safety concerns, and arrange an office visit as soon as possible. In contrast, patients who express suicidal or homicidal ideation require immediate emergency psychiatric evaluation. Case 2. A 6-year-old boy is brought to the office by his mother because of frequent nighttime awakenings. Over the past several months, he has experienced weekly episodes in which he suddenly wakes up screaming during the night. His mother says, "He seems fine when we are reading his bedtime story, but 1 to 2 hours after falling asleep, he wakes up shrieking. He looks scared, hyperventilates, and cries. When I try to hug him, he pushes me away and eventually falls back asleep." The mother worries that the patient may have been frightened by horror movies watched with his older brother. However, she also mentions that the next morning the child does not remember any dreams or even waking up during the night. The question asks for the most likely diagnosis. The correct answer is sleep terrors. Sleep terrors are characterized by sudden nighttime awakenings associated with intense fear, screaming, crying, autonomic activation, and inability to be comforted. They are classified as non-rapid eye movement parasomnias and most commonly occur in children between ages 2 and 12 years, with peak incidence around 5 to 7 years old. Sleep terrors occur during slow-wave sleep in the first half of the night. Importantly, the child does not fully awaken during the episode, and there is usually no associated dream recall. Most children have no memory of the event the following morning. This finding helps distinguish sleep terrors from nightmares. Nightmares occur during REM sleep, are associated with vivid dream recall, and usually cause complete awakening. In most cases, sleep terrors are benign and resolve spontaneously within 1 to 2 years without treatment. Case 3. A 67-year-old woman comes to the office because of difficulty concentrating. She reports repeatedly reading the same page because she cannot maintain focus. She also describes mild memory difficulties, explaining that it sometimes takes her a while to remember another person's name. Her medical history is significant for hypertension and type 2 diabetes mellitus, both of which are well controlled through diet, exercise, and oral medication. She lives alone and describes her mood as good. Her blood pressure is 127/67 millimeters of mercury, and pulse is 65. The physician decides to perform a brief cognitive assessment. The question asks which cognitive testing task would best assess attention and concentration in this patient. The correct answer is reciting the months of the year backwards. Several quick bedside tasks can evaluate attention and concentration in patients with possible cognitive impairment. Examples include counting backward from 100 by intervals of 3 or 7, spelling words backward, or reciting the months of the year in reverse order. Asking a patient to recite the months backward is especially useful in patients who may have lower educational levels or discomfort with mathematics or spelling tasks. Attention and concentration are also evaluated in the Montreal Cognitive Assessment, commonly known as the MoCA. This is a widely used screening tool for cognitive impairment that evaluates multiple domains including attention, executive function, memory registration and recall, language, visual spatial ability, and orientation to time and place. Interpretation of cognitive testing must consider factors such as education level, language barriers, visual impairment, and motor limitations. In order to diagnose dementia, a patient must demonstrate impairment in more than one cognitive domain in addition to functional impairment affecting activities of daily living such as cooking, shopping, bathing, or medication management. Case 4. A 27-year-old man leaves the restroom of a bar after smoking an unknown substance. Soon afterward, he becomes disoriented and belligerent. He develops uncoordinated jerky movements and violently assaults a bouncer attempting to calm him. When police and emergency medical services arrive, the patient fights off 4 officers before being restrained and appears almost immune to pain. In the emergency department, he experiences visual hallucinations, alternates between agitation and sedation, and cannot cooperate with the interview. Vital signs reveal hypertension and tachycardia, and physical examination demonstrates vertical nystagmus. Several hours later, the patient cannot remember most of the preceding events. The question asks for the mechanism of action of the substance involved. The correct answer is N-methyl D-aspartate receptor antagonism. This patient most likely has phencyclidine intoxication, also known as PCP intoxication. Phencyclidine is a dissociative hallucinogen that primarily acts as an N-methyl D-aspartate, or NMDA, glutamate receptor antagonist. Although the precise mechanism is not completely understood, NMDA receptor hypofunction is believed to contribute to psychosis through dysregulation of dopamine pathways. Other drugs with NMDA receptor antagonist activity include ketamine and dextromethorphan. In addition to NMDA antagonism, phencyclidine may inhibit reuptake of norepinephrine, dopamine, and serotonin, and can also affect neuronal sigma receptors. Lower or moderate doses produce dissociative symptoms, while higher doses may cause severe agitation, hallucinations, violent behavior, and psychosis. Classic clinical findings include belligerence, disorientation, loss of coordination, horizontal or vertical nystagmus, poor judgment, memory impairment, and decreased sensitivity to pain. Importantly, fatalities associated with PCP are often related not to direct toxicity, but to trauma caused by violent and dangerous behavior during intoxication. Case 5. A 32-year-old man is brought to the emergency department by police after an altercation at a local swimming pool. He is extremely agitated and complains of chest pain. Vital signs reveal a blood pressure of 170/100 millimeters of mercury and a pulse of 130 beats per minute. On physical examination, the patient is combative and incooperative. His pupils are dilated but reactive to light, and there are no signs of physical trauma. Examination also reveals nasal septal perforation. An electrocardiogram demonstrates myocardial ischemia. The question asks which process is most likely inhibited in this patient. The correct answer is inhibition of monoamine reuptake, specifically norepinephrine, dopamine, and serotonin reuptake, resulting in sympathetic stimulation and central nervous system activation. This patient most likely has cocaine intoxication. Cocaine is a powerful stimulant that inhibits presynaptic reuptake of norepinephrine, dopamine, and serotonin, leading to increased sympathetic nervous system activity and central nervous system stimulation. Patients with cocaine intoxication commonly present with agitation, tachycardia, hypertension, chest pain, and mydriasis with preserved light reactivity. Cocaine is also a potent vasoconstrictor. Its ability to increase synaptic norepinephrine, combined with sodium channel antagonism, promotes coronary vasospasm and platelet aggregation, increasing the risk of myocardial ischemia and thrombus formation. When used intranasally, cocaine's intense vasoconstrictive effects cause local ischemia of the nasal mucosa. Over time, this may lead to mucosal atrophy and nasal septal perforation, which is highly suggestive of chronic cocaine abuse. Thank you for studying with Easy Medicine. If you found this high-yield psychiatry review helpful, make sure to subscribe and turn on notifications so you do not miss future Step 1 in clinical medicine reviews. Our goal is to make complex medical concepts easier to understand through clear, high-yield clinical cases designed for efficient learning and long-term retention.
Welcome back to Easy Medicine. In today's psychiatry review, we will cover high-yield clinical cases. These involve schizoaffective disorder, delirium, major depressive disorder, opioid-seeking behavior, and acute stress disorder. These are important concepts for Step 1 and clinical practice, so let's begin. Case 1. Schizoaffective disorder. A 33-year-old man is hospitalized after neighbors called the police because he had been singing loudly and playing the piano non-stop. He says his mood is terrific, claims he is related to the president, and hears voices telling him he will be a famous entertainer. While in the hospital, he makes inappropriate sexual advances toward female nurses. He has a history of 9 psychiatric hospitalizations beginning at age 20 due to mood and psychotic symptoms. Between hospitalizations, he heard voices commenting on his appearance and believed secret cameras were monitoring him. However, during those periods, he did not have mood symptoms. What is the diagnosis in this patient? The correct answer is schizoaffective disorder. This patient demonstrates symptoms of mania, including elevated mood, decreased need for sleep, and grandiose delusions. He also has a history of hallucinations and delusions occurring independently of mood episodes. A key requirement for schizoaffective disorder is at least 2 weeks of psychotic symptoms without a major mood episode. This helps differentiate it from bipolar disorder or major depressive disorder with psychotic features. In bipolar or major depression with psychotic features, psychotic symptoms occur only during mood episodes. In schizophrenia, prominent mood episodes meeting criteria for mania or depression are absent. Case 2. Delirium. An 83-year-old woman is brought from a nursing home to the emergency department for mental status changes. At baseline, she has mild memory impairment, but is normally calm, cooperative, and cognitively functional. Over the past 24 hours, she has become increasingly combative, agitated, and stayed awake all night. Behavioral interventions and environmental modifications have not improved her symptoms. Her medical history includes hypertension, anxiety, and depression. Vital signs are normal. Neurologic examination is normal, but she cannot maintain attention during conversation. She is mildly disoriented. She cannot state the days of the week backwards. Without provocation, she suddenly strikes a nurse. Laboratory studies are normal except for urinalysis, which shows white blood cells and positive nitrites. Which medication is most appropriate to treat her behavioral symptoms in addition to antibiotic therapy? The correct answer is haloperidol. This patient has delirium. Delirium is an acute confusional state characterized by fluctuating mental status changes. Patients may also develop agitation, psychosis, disorientation, and sleep disturbances. Delirium commonly occurs secondary to underlying medical conditions such as urinary tract infections, especially in elderly patients. The primary treatment is management of the underlying cause. However, when the patient becomes a danger to themselves or others and behavioral interventions fail, antipsychotics may be necessary. High-potency first-generation antipsychotic, such as haloperidol, are commonly used for acute agitation associated with delirium. Some second-generation antipsychotics, like quetiapine, may also be used. When given at low doses and for short durations, the benefits can outweigh the risks in severely agitated elderly patients. Case 3. Major depressive disorder. A 45-year-old woman comes to the office with fatigue, weight gain, and insomnia for the past 2 months. She has difficulty falling asleep and awakens at 4 a.m., remaining awake for the rest of the day. She also reports muscle aches and pain involving the shoulders, neck, and abdomen. The patient says, "I used to be healthy, but now I worry that something is wrong or that I could have cancer." She has stopped exercising due to low motivation and has lost interest in spending time with friends and family. Medical history includes hypertension treated with hydrochlorothiazide. Blood pressure is mildly elevated at 140 to over 88, and she has gained to 0.7 kilograms. She admits becoming forgetful and sometimes forgetting to take her medication. Laboratory studies are normal. During the interview, she appears tense and anxious. What is the diagnosis in this patient? The correct answer is major depressive disorder. This patient has classic symptoms of depression, including low energy, insomnia with early morning awakening, and impaired concentration. Also weight gain, forgetfulness, and anhedonia, which is the loss of interest in activities. Some patients with major depressive disorder may not openly describe feeling depressed. Instead, they present with excessive concern about physical health, pain symptoms, or generalized somatic complaints. Common somatic symptoms include fatigue, headaches, muscle aches, abdominal discomfort, sleep disturbances, and appetite changes. When medical causes are ruled out, major depressive disorder should remain high on the differential diagnosis. Generalized anxiety disorder usually involves multiple excessive worries lasting more than 6 months. Illness anxiety disorder involves excessive fear of serious illness with health-related behaviors lasting longer than 6 months. Somatic symptom disorder involves excessive focus and anxiety regarding bodily symptoms for more than 6 months. These somatic symptom disorders are not diagnosed if symptoms occur only during an acute depressive episode. Case 4. Opioid-seeking behavior. A 32-year-old woman comes to the emergency department requesting medication for severe back pain. She states that only oxycodone relieves her pain. She was seen at a pain clinic 1 year ago, but cannot remember the physician's name and says that her prescription has run out. Medical history includes obesity and a motor vehicle accident 10 years earlier. Vital signs are normal. Physical examination is unremarkable, and MRI findings are normal. Despite this, the patient reports that her pain is 10 out of 10 and becomes frustrated when non-prescription pain medications are suggested. What is the next step in management? The correct answer is to obtain confirmation of the patient's prescription history. Emergency physicians frequently encounter patients requesting opioid medications for pain. It is important to distinguish inadequate pain control from drug-seeking behavior. This patient demonstrates several red flags for opioid misuse. These include requesting a specific opioid by name, reporting that medications have run out, and pain inconsistent with findings. Other warning signs include claiming medications were lost or stolen and obtaining prescriptions from multiple providers. The best initial step is reviewing the patient's prescription history. Prescription drug monitoring programs help identify and disclose the opioid prescriptions, abnormal patterns, and potential misuse. This allows physicians to make safer and more informed prescribing decisions. Case 5. Acute stress disorder. A 28-year-old medical student comes to the office due to anxiety and difficulty concentrating. 3 weeks ago, during volunteer work, he witnessed a child burning to death. Since then, he has experienced episodes of sweating, shaking, shortness of breath, and panic-like symptoms. The patient says, "I feel like my head was spinning," and reports running out of the classroom to catch his breath. He also reports insomnia, irritability, and episodes where he feels detached from reality, almost as if he is in a dream. The patient says, "Sometimes I suddenly feel like I am back in the burning house. I can smell the fire and see the child." He has missed nearly half of his classes to avoid crowded classrooms and recently quit his volunteer job. What is the diagnosis in this patient? The correct answer is acute stress disorder. This patient demonstrates intrusive flashbacks, hyperarousal, panic-like symptoms, irritability, and sleep disturbance, also derealization and avoidance behaviors following a traumatic event. Acute stress disorder develops shortly after trauma and lasts between 3 days and 1 month. Common symptoms include nightmares, depressed mood, difficulty concentrating, hypervigilance, and decreased interest in activities. Reminders of the traumatic event can trigger severe anxiety and panic, leading to avoidance and functional impairment. When symptoms persist longer than 1 month, the diagnosis changes from acute stress disorder to post-traumatic stress disorder. Thank you for studying with Easy Medicine. If these high-yield psychiatry cases helped you understand difficult concepts more clearly, make sure to subscribe, like the video, and continue reviewing with us for more Step 1 and clinical medicine content made simple.
Welcome back to Easy Medicine. Today we're covering 6 high-yield pharmacology cases involving angina, hypersensitivity reactions, polypharmacy, stroke prevention, transplant medicine, and targeted cancer therapies made simple. Case 1. A 71-year-old man with chronic stable angina comes to the office for routine follow-up. He reports recurrent episodes of chest pain that consistently improve after taking sublingual nitroglycerin. His medical history is significant for hypertension and hypercholesterolemia, and he currently takes multiple medications. Blood pressure is 140/80 mmHg, and pulse is 68 beats per minute and regular. Cardiac examination reveals normal heart sounds. During discussion about starting isosorbide dinitrate therapy, the patient becomes concerned because the oral dose appears much higher compared with his sublingual nitroglycerin. The question here is, what is the most likely reason for using a higher oral nitrate dose? The correct answer is extensive first-pass metabolism. Nitrates, beta blockers, and calcium channel blockers are major therapies used in chronic stable angina. Sublingual nitroglycerin is preferred during acute episodes because it provides rapid symptom relief and can also be used before strenuous activity to prevent angina. Long-acting nitrates such as oral isosorbide dinitrate or isosorbide mononitrate are primarily used for prevention of recurrent episodes. Sublingual nitroglycerin is rapidly absorbed through oral mucosa directly into venous circulation and begins working within approximately 2 to 5 minutes. In contrast, oral isosorbide dinitrate is absorbed through the gastrointestinal tract and undergoes extensive first-pass metabolism in the liver before reaching systemic circulation. This significantly reduces bioavailability and explains why much larger oral doses are required. Case 2. An 8-year-old boy returns to the emergency department because of a pruritic rash that began 30 minutes ago. Earlier today, he was diagnosed with acute tonsillopharyngitis and prescribed oral amoxicillin. He has no known drug allergies, but previously received penicillin on one occasion. Vital signs are normal. Physical examination demonstrates urticaria involving the torso and extremities along with faint bilateral wheezing. The question here is, which factor was most essential for this adverse reaction to occur? The correct answer is formation of hapten carrier protein combination antigens. This patient likely developed an IgE-mediated type 1 hypersensitivity reaction after exposure to a beta-lactam antibiotic. Most drugs are too small to trigger immune responses alone, but certain medications or metabolites can function as haptens that bind carrier proteins and create immunogenic complexes. Beta-lactam antibiotics commonly cause this phenomenon. During previous exposure to penicillin, sensitization occurred with production of IgE antibodies directed against beta-lactam carrier protein complexes. These antibodies attach to mast cells and basophils, preparing the immune system for future exposures. When exposed again through amoxicillin, similar antigen complexes formed and cross-linked surface IgE antibodies, causing massive mast cell degranulation with release of histamine and inflammatory mediators. This produces immediate allergic reactions such as urticaria, erythema, wheals, bronchoconstriction with wheezing, and in severe cases, anaphylaxis. Case 3. An 82-year-old woman presents for a new patient evaluation after recently moving in with her daughter. She reports frequent dizziness, but cannot provide additional details. Medical history includes moderate dementia, hypertension, transient ischemic attack, depression, and chronic insomnia. Blood pressure is 124/72 mmHg, and pulse is 66 beats per minute, and regular. Neurologic examination reveals disorientation to time and place, but normal reflexes without focal deficits. Review of medications shows she currently takes 12 different medications. The question here is, which medication should be discontinued? Options include amlodipine, aspirin, diphenhydramine, donepezil, hydrochlorothiazide, and sertraline. The correct answer is diphenhydramine. Older adults are particularly vulnerable to medication adverse effects because of reduced drug clearance, cognitive impairment, sensory deficits, multiple comorbidities, drug interactions, and poor medication adherence. Polypharmacy, generally defined as more than 5 medications, significantly increases risk and may produce prescribing cascades where adverse effects are mistaken for new diseases. The Beers criteria identify medications that should be avoided or used cautiously in geriatric populations. First-generation antihistamines, such as diphenhydramine, have strong anticholinergic effects and can increase confusion, hallucinations, dizziness, dry mouth, constipation, and fall risk. Other medications frequently avoided in elderly patients include benzodiazepines, sedating antipsychotics, digoxin, and centrally acting muscle relaxants. Case 4. A 64-year-old woman presents after experiencing sudden onset right arm weakness and difficulty speaking that completely resolved within 20 minutes. She denies headache, shaking movements, nausea, photophobia, or anxiety. Medical history includes hypertension and hypercholesterolemia, treated with amlodipine and rosuvastatin. Blood pressure is 125/70 Hg, and pulse is 78 beats per minute and regular. Neurologic examination is normal. Fingerstick glucose is normal. Electrocardiogram shows sinus rhythm. Carotid Doppler reveals mild left carotid stenosis, and MRI and echocardiogram are unremarkable. The question here is, if an additional medication indicated for her condition is started, which adverse effect is most likely? The correct answer is gastrointestinal bleeding. This patient most likely experienced a transient ischemic attack because neurologic deficits developed suddenly and completely resolved. Beyond blood pressure control and statin therapy, low-dose aspirin is commonly prescribed to reduce future ischemic stroke risk. Aspirin irreversibly inhibits cyclooxygenase enzymes. At low doses, it preferentially inhibits COX-1, reducing thromboxane A2 production, decreasing platelet aggregation, and reducing vasoconstriction. Aspirin increases upper gastrointestinal bleeding risk through inhibition of platelet function and impairment of prostaglandin-mediated gastric mucosal protection. Even low-dose aspirin increases upper GI bleeding risk approximately 2 to 3 times. Proton pump inhibitors may help reduce this risk. Case 5. A 34-year-old kidney transplant recipient treated with cyclosporine presents with nausea and anorexia. Transplantation occurred 6 months ago, and he had previously done well. Blood pressure is now 160/96 mmHg. Examination reveals no tenderness over the transplanted kidney. Laboratory studies demonstrate creatinine of 3.4 milligrams per deciliter and markedly elevated cyclosporine levels. 1 month earlier, blood pressure, creatinine, and cyclosporine levels were normal. Further questioning reveals increased grapefruit juice consumption because he believed it would improve his health. The question here is, what mechanism explains this patient's condition? The correct answer is inhibition of cytochrome P450 enzymes in the gut wall. This patient demonstrates calcineurin inhibitor nephrotoxicity, characterized by hypertension, elevated creatinine, and increased drug levels. Calcineurin inhibitors such as cyclosporine cause dose-dependent renal vasoconstriction and tubular injury that can precipitate acute kidney injury. Grapefruit juice inhibits intestinal CYP450 enzymes, decreasing drug metabolism and dramatically increasing systemic drug levels. Case 6. A clinical trial evaluates a novel formulation of cisplatin for advanced non-small cell lung cancer. Participants are randomly assigned to conventional cisplatin chemotherapy, or to a formulation where cisplatin is encapsulated within liposomes, coated with anti-epidermal growth factor receptor antibodies. Patients receiving the experimental therapy demonstrate significantly lower residual tumor burden and fewer adverse effects. The question here is, compared with conventional cisplatin, what effect is this formulation most likely to produce? The correct answer is selective drug uptake by cancer cells. Platinum chemotherapy agents such as cisplatin remain first-line therapy for many solid tumors, including non-small cell lung cancer. These agents interfere with DNA replication and effectively kill rapidly dividing cells, but their use is limited by significant toxicities, including nephrotoxicity, ototoxicity, and myelosuppression resulting from accumulation within healthy tissues. Targeted delivery systems attempt to maximize tumor exposure while minimizing toxicity. In this example, cisplatin is packaged within liposomes, creating nanoparticle carriers that reduce interaction with healthy tissue. Addition of anti-epidermal growth factor receptor antibodies creates an antibody-drug conjugate that preferentially binds tumor cells overexpressing epidermal growth factor receptors, which commonly occurs in non-small cell lung cancer. After binding, the complex undergoes internalization and degradation, releasing free drug inside cancer cells and producing targeted cytotoxicity. If these cases helped simplify pharmacology, keep studying with Easy Medicine. Remember, understanding mechanisms is what transforms memorization into real medical knowledge. Welcome back to Easy Medicine. Today we'll review 6 high-yield psychiatry and pharmacology clinical cases designed for Step 1 preparation. These cases will help reinforce medications, substance use disorders, psychosis, anxiety disorders, and psychiatric treatment principles through clinical reasoning and board-style questions. Case 1. A 45-year-old woman with a history of opioid use disorder and HIV infection is brought to the emergency department because of worsening lethargy. She receives methadone maintenance therapy, which she recently restarted after hospitalization for an HIV-related infection. Her infection improved and she continues outpatient antimicrobial therapy. Her temperature is normal and vital signs are stable. Physical examination reveals somnolence, sluggish pupils, and withdrawal to painful stimuli. Brain imaging shows no acute abnormalities, and renal function is normal. The question is, which medication most likely contributed to this patient's current condition? The correct answer is fluconazole. Methadone is a mu-opioid receptor agonist commonly used for opioid use disorder maintenance therapy. Because of its long half-life, it effectively suppresses cravings and withdrawal symptoms. However, methadone overdose can cause somnolence, meiosis, respiratory depression, and can also prolong the QT interval, increasing the risk for torsades de pointe. Methadone is metabolized primarily through cytochrome P450 enzymes, especially CYP3A4. In this patient, fluconazole, commonly used to treat cryptococcal meningitis in severely immunocompromised patients, inhibits CYP3A4 metabolism. This causes methadone levels to increase, leading to opioid toxicity. Case 2. A 42-year-old man is hospitalized after a motor vehicle collision caused by alcohol intoxication. He undergoes surgical repair for tibia and fibula fractures. On hospital day 3, he suddenly becomes agitated and demands discharge. Vital signs reveal hypertension and tachycardia. Physical examination shows diaphoresis, tremors, disorientation, and autonomic hyperactivity. The question is, increased activity of which central nervous system receptor is most responsible for this patient's symptoms? The correct answer is the NMDA glutamate receptor. This patient developed alcohol withdrawal after forced abstinence during hospitalization. Alcohol normally enhances inhibitory GABA activity while simultaneously suppressing excitatory glutamate signaling through NMDA receptor inhibition. With chronic alcohol exposure, the brain compensates by decreasing GABA receptor activity and increasing NMDA receptor expression. When alcohol is abruptly removed, inhibitory signaling falls while excitatory signaling dramatically increases. The result is central nervous system overexcitation, causing tremors, agitation, autonomic instability, and confusion. Therefore, increased NMDA receptor activity is responsible for this patient's symptoms. Case 3. A 20-year-old man is brought to the emergency department because his roommate found him barricaded inside a closet saying, "They are coming to get me." Over the last month, the patient lost his job and experienced a breakup. During the past 2 weeks, he has heard threatening voices several times daily. Physical examination and laboratory testing are normal. Mental status examination reveals paranoia, fearfulness, and delusions involving men following him in black cars. The question is, what is the most likely diagnosis? The correct answer is brief psychotic disorder. This patient demonstrates hallucinations and paranoid delusions lasting 2 weeks after significant emotional stressors. Brief psychotic disorder requires psychotic symptoms lasting greater than 1 day, but less than 1 month, with eventual return to baseline functioning. Duration is critical when differentiating psychotic disorders. Symptoms lasting more than 1 month, but less than 6 months, suggests schizophreniform disorder. Symptoms lasting longer than 6 months suggest schizophrenia. Case 4. A 14-year-old boy is brought to the emergency department after being found staggering between classes at school. Initially, he was lethargic, disoriented, and had slurred speech, but symptoms improved significantly within 30 minutes. On arrival to the emergency department, he appears alert and oriented. The diagnosis is use of inhalants. Physical examination reveals abrasions and a rash around the nostrils and mouth. These substances are frequently among the first drugs misused by adolescents because they are inexpensive and widely available. Case 5. A 20-year-old man is hospitalized after being found shouting and laughing alone in a park. He wears an aluminum foil-lined hat because he believes laser beams are attempting to reprogram his brain. For the past 3 years, he has heard voices of deceased relatives, famous individuals, and supernatural figures. He previously responded well to haloperidol, but discontinued treatment because he disliked the side effects. A decision is made to start a second-generation antipsychotic. The question is, compared with first-generation antipsychotics, what advantage does this class provide? The correct answer is lower risk of acute dystonia. This patient most likely has schizophrenia, characterized by chronic psychotic symptoms with onset during young adulthood. First-generation antipsychotics strongly block D2 receptors, producing extrapyramidal side effects such as acute dystonia, Parkinsonism, akathisia, and tardive dyskinesia. Second-generation antipsychotics generally produce fewer extrapyramidal symptoms, making them preferred first-line therapy. However, these medications carry higher metabolic risk, including weight gain and diabetes. Olanzapine and clozapine have particularly high metabolic risk profiles. Case 6. A 34-year-old woman presents for a routine employment physical examination. During blood collection, she suddenly develops anxiety, nausea, shortness of breath, and dizziness. Her husband explains she has experienced similar episodes since childhood after suffering a traumatic accident involving significant bleeding. Physical examination is otherwise normal. The question is, what is the most likely diagnosis? The correct answer is specific phobia. This patient demonstrates severe anxiety triggered by blood exposure with long-standing avoidance behavior. This presentation is consistent with blood injection injury type, specific phobia. Unlike many anxiety disorders, this subtype frequently produces a vagal response that can lead to fainting. Specific phobias may also involve animals, heights, storms, enclosed spaces, elevators, or airplanes. The treatment of choice is cognitive behavioral therapy, with gradual exposure to the feared stimulus. These clinical cases highlight some of the most important Step 1 concepts involving pharmacology, psychiatry, substance use disorders, and behavioral medicine. If you found these cases useful for your studies, continue practicing high-yield clinical reasoning because repetition is what transforms memorization into mastery.